Hey, hello, Gena. Hi, I'm James. I'm really grateful that you were able to be able to interview for this because I'm not a hospital social worker and I don't really know what it's like being a hospital social worker. And you being a graduate from the IU School of Social Work program and who have landed this great job at a hospital, I was wondering, can you tell us a little bit about the hospital and the role you fill as a hospital social worker?
Sure. So I'm a medical social worker in the Integrated Care Management department over at IU Health Bloomington Hospital. It's not a very big hospital by national standards. We've just got a little over 200 beds in the hospital, so it's pretty small. I am one of 4 medical social workers that work in the department. There are other social workers that work in other disciplines in the hospital, provide counseling or an inpatient psych, but our role is to assess patients for needs that might affect their discharge and also affect their readmission rates to the hospital. Okay, so we get called in often to work with the care managers who are there, and they're the ones who are actually doing discharge planning from a medical standpoint. We're there to address more of their psychosocial needs.
Wow, fantastic. How do you collaborate with the medical personnel within that environment and the needs of individual patients? It's kind of a big deal here.
There are a lot of people that come together to work as a team, and as part of that, we meet a few times a week with a multidisciplinary team, and we do what's called rounding, and it's different than maybe what you might expect rounds to be when you see them on TV. You see people walking through rooms and meeting individually with patients, and doctors are there kind of running it. Most of the rounds that I attend don't have a physician there, and it's other disciplines. A charge nurse from the floor is there, and they're the ones that run the rounds, and they go through each individual patient who's on their floor that day.
And you're with them?
And I'm with them.
Okay.
Yep. And it usually takes about an hour, depending on our census and the level of need of our patients. There are nutritionists there, the social workers there, the care manager, a pharmacist, a chaplain. So there are quite a few disciplines that all get together.
The care manager, would that be the nurse that you?
It's a nurse case manager or care manager.
Okay.
And they're the people that I work probably most closely with in arranging for safe discharge and resources for patients when they're leaving the hospital.
Wow.
Yeah.
Fantastic.
So that's pretty exciting to get to work with all those different people together.
Yeah. So when you see your role in that, do you feel like as a school social worker, because I wasn't a teacher, right, or a school counselor, there was always kind of like a feeling of a little bit of an outsider that was working on the inside. Is it like that for you as a medical social worker? Do you feel like they've allowed your role to be an insider and you feel like I am a part of this team?
I think I got some good training at the School of Social Work and also from people that I worked with through my practicum placements in developing a sense of my own professionalism maybe. One of the social workers that I went through with my practicum talked about you're just as much of a professional and as important to that person's stay here at the hospital, and you kind of have to walk in with the attitude that I'm just as important. I'm here as a clinician as well, and my opinion matters. And I think if you are able to adopt that kind of an attitude about yourself, that other people see that, and I feel very well respected, and I feel like my opinion is valued. So I haven't really had an issue with that. I've heard from other people, maybe in other settings, that they have an issue with it, but I think it's just...
I like that attitude in having, I'm wanted, I'm needed, I am part of this, and playing that out. That is really awesome.
And I think having an awareness that other people might deal with that too is something that's important.
Okay. Are there some hospital norms that you had to adjust to that may have been very different from your own culture of origin, so to speak, or training?
Sure. I think one of the the big things when you first come in is that we will refer to clients as patients. And I think that was something throughout school, that don't call them patients, they're always clients. But that's, maybe we're ascribing more to a medical model when we're calling them patients. It's just, that's one of those norms. What we wear is a little bit different. I wear actually a white lab coat, which is what maybe doctors and pharmacists are wearing too. That can be confusing for patients sometimes when you're walking into a room.
Perhaps.
You're in a uniform, and I think that there's a little to overcome sometimes with that when you're building rapport with a client. So that's maybe not a norm that you'd have in social work.
Yeah, and is that to create like legitimacy maybe?
Mm-hmm.
This is okay.
Yeah, and that, just to have everyone look a little bit more the same and to provide some assurance to patients that you're a professional coming into their room.
Is hygiene any different? I picture medical, they're very careful about spreading of germs. And
so we don't have to necessarily wash our hands when we walk in, because we don't have access to a sink in every patient's room, but there's hand sanitizer. So when I walk into a room, I am using hand sanitizer in front of a patient, because you want them to know that you're there and you're addressing their concerns, that it's clean and safe for them. One of the other things that we have to address as far as hygiene too is that a lot of the patients I work with are on isolation for some sort of maybe they've got MRSA. And so because
MRSA being?
That's, you put me on the spot, but it's an infection that's resistant to antibiotics.
Oh, okay.
And because I'm walking into multiple patients' rooms, if I'm walking into someone's room who, say, has an infection like this, then I walk into someone else's room, I might be taking that with me.
Okay.
So we do have to gown up sometimes. I'm having to wear a mask and gloves and a gown to cover all of my clothes when I'm going in to meet with patients, so I'm not carrying that on to other people. So that can be hard too when you're trying to do an assessment and you're wearing a big mask on your face.
And trying to be personal.
Yeah, it's hard. And they don't recognize me when I come back in either, and so that can be a challenge.
Okay. What kind of crises do you attend to in a hospital? At your hospital?
I would say that that's a pretty major part of my job. I work on the oncology floor and on the renal or nephrology unit, where there are a lot of dialysis patients. And then I also rotate and cover the emergency room. So I deal with a lot of people who are experiencing chronic illness, a lot of people who might be at end of life, and also helping their families to deal with that. And a lot of times in the emergency department, we're called in to deal with what we call a code. And that might be someone that they've stopped breathing or their heart has stopped. And those are certainly crisis situations.
Well, it sounds like you deal with a lot of crises per day then.
Mm-hmm. Could be, yeah, and you never quite know what you're gonna, walk into that day. So you just have to kind of be ready to roll.
Could you walk us through a crisis?
Sure.
Yeah.
I can give you an example of one that involved a lot of different disciplines and a lot of different community agencies.
Nice.
So I would say that this is something that we're walking in and trying to get a hold of the situation and maybe be there as a liaison between the family and patient and all these different agencies. One where that can get quite complicated is when a child dies suddenly. We're called in to provide support. And when a child passes away very suddenly and it's not explained, then we're also dealing with the coroner and often law enforcement and Department of Child Services. And we're kind of pulled in many different directions because we're there to act as a liaison with those agencies, but we're also trying to provide support to a family that has experienced an enormous loss quite suddenly and many times unexplained. So we'll get called to the emergency department in a situation like that. We usually only have a few minutes notice. We're called in, we have a small, what we call a consultation room, where we meet with the family. And a lot of times we're there and present when physicians come in to let the family know that their loved one has passed. And it's very immediately, the energy in the room rises, and I kind of refer to it as riding a wave with the family, and it's never a more urgent situation to meet someone where they are. When we refer to social work, that meet them where they are at that point.
Yeah.
Because we are really just there kind of riding this wave of grief and shock with people, trying to quickly assess for safety and what is it that I can do for you right now. And also pulling in other people for them if they're alone. So that's my number one job when I walk in. Who else can I get to be here with you? Because I can be there to be empathetic to the situation, but I don't know them the way that a family or a friend would. So I'm trying to also get other people to come in.
So really looking at it from an ecological perspective of looking at outside resources, those personal connections that they have, and linking them in that crisis.
Mm-hmm. Yeah.
Wow.
It can be really intense, but I think those moments are also really satisfying as a social worker because you feel like you've been able to be there at a moment where someone really needed some help and someone to be able to be an anchor and to get them through that crisis.
Yeah, and I picture that wave that you're saying,
Mm-hmm.
you know, so here's this wave that has just crashed, and it's just bubbling and throwing foam everywhere,
Mm-hmm.
so to speak, from that wave, and social work being somewhat of what you call it, an anchor, but that stabilizing
Mm-hmm.
voice and presence as that wave tries to reconfigure itself.
Mm-hmm.
Yeah.
And to get them back to that point where they can at least function and move on to the next step, because they don't have questions when that first happens. It's just a complete emotional and shock reaction.
Yeah.
Mm-hmm. And then eventually things will calm down after, say, an hour or two, and then that's when you're there to provide resources about what do we do next. And then you're hooking them up with other resources outside the hospital, not necessarily bereavement, but then we're moving right into funeral planning and things like that. And then you're also trying to help coordinate with DCS and law enforcement, and that's probably the most intense day that I have.
Wow.
Yeah.
I'm picturing at this phase, the physicians really appreciate social work.
I think so.
Yeah.
They seem to be thankful that we're there. Mm-hmm.
Great. Okay, is there a model of crisis intervention? Say, you have a patient
Mm-hmm.
who is in because of, let's say, alcohol withdrawal, and all of a sudden that patient starts to have tremors or a seizure or something. Is there like a crisis model that you use? And, you know, if, let's say, the partner of that patient is, you know, really losing it within the room there, and
Mm-hmm.
you're in there and this is happening. I mean,
I don't know that I have a specific crisis model. I remember, I think it was Robert's crisis intervention that we talked about in school, and I would say pretty much everything that we do in the hospital is very brief, maybe condensed or abridged of what you might see in other social work settings, just because I don't get to spend a lot of time with my patients, and I'm probably not going to see them again. I might see them once, twice, sometimes 3 times, but I've got to get in and assess the situation,
Mm-hmm.
quickly build rapport with people, especially in a crisis situation, and typically, I have a little bit of a cheat with it because I've been called in and sort of know what it is that they are needing help with at that point. And then I'd say the most important piece is finding out what resources do they already have in place that I can help them and empower them to access those resources right now, because they're not going to come back to me probably. So that's...
Is there anything that you use for de-escalation in particular, to de-escalate? Maybe situations where there's a lot of anger or a lot of emotional, maybe not through a child's death, but through something that's happening within the room at the moment. Just wondering if...
Something that comes to mind is when I'm meeting with patients who've maybe just received a new diagnosis, and a lot of times we'll see patients who find out that they have cancer. And that can be a very overwhelming, it always is overwhelming, because we're talking to them about scheduling chemotherapy appointments, getting an oncologist, possibly starting radiation. How are they going to get back and forth? How are they going to pay for this? How are they going to tell their families
So
about
there's a lot of
this?
flooding.
It's a huge flood, and we're walking in to just sort of help them, I would say partializing, what is it that you can control today?
Mhm.
And I use that a lot. What is it that we can focus on right now today? And the rest of this will come at some point, but right now today, what can you control?
So it really sounds like you help the patient and family break it down into manageable pieces versus the whole.
Yeah, because
Yeah.
they're meeting with all of these people, different professionals are coming in all day long, and things happen very quickly, and it gets very overwhelming for them. So also just saying, we're here, and we can carry a little bit of that for you and keep track of it. Just take it one piece at a time.
Well, one thing I'm really getting from listening to you is you really tune into the frequency of what's going on with your patient and the family in that moment, and I think that's just really indicative of excellent social work practice, you know. So it's really great to hear. Can you tell me, Gena, about charting and responsibilities that go along with charting? This is unfamiliar territory to me.
Okay. Well, then you're lucky then.
Yes.
We're responsible pretty much to record everything that we're doing with a patient.
Okay.
And one of the most important reasons is that we're helping to build a discharge plan with our care managers. They need to be able to go in to look to see what is it that we have assessed for so that they can meet those needs, say in scheduling follow-up appointments or home health for a patient. So if I'm talking to someone and they're telling me that their housing situation isn't necessarily ideal, or that they're living in an apartment on the second floor and they've been having a hard time getting up and down the stairs, that information is important for me to put into my assessment so that the care manager can then go in and say, wow, I need to get some resources for this person, maybe some home health, maybe some durable medical equipment that might be helpful to them.
So it sounds like charting is in part like doing some assessment of maybe the here and now, but also some of the future obstacles or barriers that may be occurring. And then the manager, what you call the manager?
The care manager,
The
nurse case manager.
Then reads that and then takes the steps to address that or tries to find resources that
From a medical standpoint that would help them.
Wow.
And I would also say charting is important for us too when we have patients who are readmitted to the hospital. We might not see them for a year or two, and I think our notes are valuable, especially to my colleagues when we work with different patients, to go back and look and see, oh, well, this is what was happening a year ago, and this was the family member that we were able to pull in. So we find that they're valuable not just to other professionals, but to social workers within our department when we meet people again.
Okay. Is the charting challenging ever to you? I mean,
It can be challenging. It's challenging for me just because I'd rather be out there talking to people and working with them than sitting at a computer charting. So that's hard for me just to take the time to sit down and to chart. I think you have to get into sort of a methodical. Every day at 2:00, I'm going to sit down and get through all the people that I've seen so far, and you just get into a time management system with it. That's what's difficult for me about it.
wow. So it sounds like it's not as it goes along, but almost like it's a side where you're collecting all the data. Do you keep it to memory and then do the charting, or?
When I first started, I took a lot of notes. And part of that is that you're not really quite sure what it is that you're looking for when you're first getting started as a social worker. So you tend to ask a lot more questions and you're writing everything down. As I've come to gain a little more experience, now I know what it is that I'm looking for and what I need to put in that note. And those questions come more easily to me. And it's more conversational for me as well. I don't need to refer to notes as I'm talking to a patient, so that's been helpful. So a lot of what I do might be from memory, phone numbers and names and things like that. I'll still take notes and write those down, but yeah, it's just kind of all in my head when I'm doing it.
That's fantastic, and I really like that piece of conversational. That's so social work versus
looking through.
Yeah, which is probably what a lot of patients do experience in hospitals. So excellent. Well, along with charting, I was wondering if you could tell a little bit about describing the discharge planning
Okay.
and how that may be different than charting.
Sure. So, as I mentioned before, that nurse care manager that's working with them is really looking at things from a medical standpoint. Does the patient need to have home health visitor? Does the patient need to have follow-up visits with, say, a specialist of some kind? I get called in to help with discharge planning when they want to work with outside agencies, and some of the places I refer to a lot are our area agency on aging. So here in Monroe County, who we deal with a lot is Area 10, and they work with aging and disabled populations. They can go into their homes and provide resources like grocery shopping or meal delivery or maybe light housekeeping. So that's not necessarily on a medical side, but more a social need that I can hook them up with. And I have relationships with people who are working at those agencies that the nurse case managers don't necessarily have. So that's why that falls to me. We also refer a lot to outside mental health agencies for people to go and get hooked up with places like Centerstone or maybe an outpatient behavioral health through our hospital. And other than that, I can't tell you, there's not a defined list. There's probably 50 different agencies that I might refer people to. So it just depends on what it is that they need. I don't write out a specific discharge plan for people.
Yeah.
The case manager does that. And the nurse is actually the one that will go over the case or the discharge plan when someone's leaving the hospital.
Okay.
There are times where if I'm concerned that a patient might have trouble understanding or it's not clear to them what they need to do, especially if they've come back in for readmissions, I'll go and sit with the patient and we'll do something called teach back, where I'm asking them, so can you tell me what it is that you heard and what you're understanding?
I have, yeah. I did that a lot often as a school social worker too, because they're very good at giving a therapeutic nod. Yes, I hear what you're saying, but then, right?
Yeah,
it's like, it's not there. Yeah.
So I'll often sit with people just to make sure that they know what it is that the nurse is telling them to do, because that nurse might be doing 5 discharges that day, and they're just trying to get through this and to make sure they're giving the information to the person. My job's to come in to help make sure that they understand that.
Wow.
So that's probably the piece that I would have the most my hand in when we're working with discharge planning, just ensuring that they're understanding what it is that they need to do when they leave.
Wow. So maybe some reflection and maybe having them repeat, can you tell me what you heard me say, kind of stuff. And, okay.
Yeah.
That's really awesome. Regarding substance abuse, do you rely on any community resources in particular for substance abuse patients?
That's probably a challenging piece of my job as far as substance abuse goes, and I would say the most challenging piece is in working with other professionals at the hospital, because we'll often get phone calls from nurses or from doctors saying this person is experiencing some sort of addiction and we need you to come in and get them into rehab. And that's the referral that I'll get. And immediately the first thing I need to know is that patient interested in addiction services or rehab?
Personal motivation fits
Yes,
in this,
because that's something I think that's maybe a little more unique in social work, that we know that that's an important piece.
Yes.
But doctors and nurses don't
They
necessarily
just want to check the box.
Yeah. Well, this guy needs this, so could you please come in and get him hooked up? So we do a lot of education with different professionals about he's just not ready and this isn't what he wants, and do a little talk about self-determination, that this is his choice to do this at this time, and he probably won't be successful if he's entering this because we're forcing him to do it.
Which is so unique to social work, right?
Yeah, absolutely.
Yeah, and our code of ethics really speaks to that, which is really great. But nurses may know he needs it because, or she needs it because, she's
They're
abusing
there to help
substance.
people.
Yeah.
That's what they want.
But the bigger picture is really important, and I think that's where social work gets it,
Mhm.
really gets it.
Yeah, so
Yeah.
we do offer resources to people, but we're definitely assessing for where are they at in readiness to change before we're making a good sort of determination about where they need to go.
Yeah. So one of the things I wonder about is if you did have a patient who was clearly demonstrating, I know I have a problem, I can't go on like this, I need some help. What community resources do you see that are important to the Bloomington area?
I would say Centerstone is the place that we most often refer people to. Or we'll send people all the way up to Indianapolis. There are several treatment centers up there. A lot of times they have to have health insurance, and that's a great barrier to people receiving treatment. The other barrier I would say is that we can't do a whole lot as far as that discharge planning, that sort of motivation for them.
Yeah.
They need to be the ones to call and to do an intake. I made that mistake when I first started at the hospital, that I tried to make a phone call for a patient to say, hey, I'm trying to make them an appointment for an intake, and they won't even accept my phone call. They will not talk to you. So that was an eye-opener for me, and I learned quickly that I need to be able to just offer those resources to the patient, and they need to take it from there.
Well, that's interesting. I'm reading a chapter right now, preparing for class, and one of the things I say is master's students have this kind of rescue thing going on, and I think social workers, on average, really want to help and take that extra step for our clients.
Yeah.
And I think the substance abuse community really gets that this self-determination, this personal motivation and investment into the process. That's what this is. Yeah, so it's interesting. And I appreciate you disclosing that, because I think all of us in the social work field, or probably mostly, will be having a similar experience somewhere along the lines where we catch
You
that.
kind of get stopped.
Yeah, yeah.
I did a little too much.
We get that feedback.
We do.
Yeah, interesting. Anything else you'd like to say about discharge plans and with patient and family? Is there anything else that?
Just in you mentioning families, that does bring up, oftentimes the patient isn't just the only client that we're working with. We're working with families too. And in substance abuse especially, I get a lot of families who are coming to me saying, this is what he really needs to do, you need to talk him into going into treatment. And that's not my role either. So a lot of times I will hook families up with, maybe an Al-Anon group or a counselor that they can go to see, because they're the ones that are having the issue right at that moment. They're having a hard time. So that might be a way for me to offer resources to the family and not just focused on the patient. Also, I see a lot of people who are experiencing caregiver stress or burnout.
Oh.
And so hooking those people up with support groups in the area, especially people who are caring for someone who has an Alzheimer's diagnosis. So we have great resources here in Monroe County and actually through IU Health where we can provide some support to them.
Cool.
So.
Perhaps respite? Is there any ever respite for the
There's
caregiver?
respite for them. Mm-hmm.
Oh, that is genuine.
It's I would say it's a really, that's one of the most important resources that we've got for people. We have support groups here where they'll actually provide supervision and therapy to patients while their family members are attending a support group for caregivers. And
Okay.
that's really valuable to us as social workers to be able to offer that to families.
Oh, I imagine so. Yeah. When are you called in to work with a patient? Like, what's that point of entry?
So we have sort of a prescribed list at the hospital that we start with, and maybe when I come in every day, I will print out my census from each of the units that I cover in the hospital and sort of do a little triage with who is it that I need to see most urgently right now.
Mm-hmm.
So doctors or nurses, even other therapists or professionals in the hospital can put in a referral so that I will receive a message saying, I need you to see this patient for this reason. So typically those are the things that I'll go to most quickly. A lot of times those involve maybe family crisis, that the family's having a difficulty coping, a patient's having difficulty coping. Lack of financial resources, we get called in for a lot. We don't necessarily help people to sign up for resources, but I might give information about how they could access an application for disability, or how they might access our patient financial services to work with someone. Then we're also seeing people who've been in the hospital for more than 7 days. And that's just because that's a long time to be in the hospital. And really after 5 or 6 days, I say to people, I'm just here to check on you, because after 5 or 6 days, these walls seem to start to close in on people, and you're not in your own environment anymore, and I just want to find out how you're doing. And most often people will say, oh my gosh, I can't take this anymore, and I've got to get out of here. So we're there to sort of just let them know it's normal that you're feeling this way, and maybe offer some tools to them for how to cope with the continued stay.
Would like arranging, if it was appropriate, like putting them in a wheelchair and just taking them out for a walk or something?
Absolutely. I'm
Okay.
getting people outside if we ever possibly can. We have a great garden at the hospital that I tell people all the time, just get outside and go sit by the fountain for 10 minutes. And it helps a lot.
Oh, I imagine.
So that's one. Trying to think of why else I get called in. I've mentioned that we work with a lot of people who are experiencing end-of-life issues, grief, and new diagnoses. And their transportation is a big one. We get called in a lot for people who don't have a ride home from the hospital. We serve, it's about 8 to 11 county radius, and a lot of rural populations. So we might have somebody that came up from Paoli in an ambulance, and that's a couple of hours away, and they don't have a ride to get back home. And so we get called in to muster up resources, and there aren't a lot. I'd say that's maybe one of the most frustrating parts of my job, is just hooking people up with transportation. You wouldn't think it is, but it's hard.
Yeah, and I'm sure insurance probably doesn't cover that.
Nope, not really. Sometimes if people have Medicaid, they can get a ride home from the hospital with that. Oftentimes they want 48 hours notice to do it, and we might have 2 hours notice that a person needs a ride home. So a lot of what we're doing then is, again, helping families or patients to muster up those resources. Who have you got? Who can we start to call to get you a ride home?
Right.
Yeah.
This is out of my own personal curiosity, but the Affordable Care Act, how have you seen that impact patients, vulnerable patients? Have you seen anything
I would
positive or
say
negative?
the Affordable Care Act, as far as people purchasing plans on the marketplace, I haven't experienced a lot of that. It's as far as problems that people have had with it, it's gone pretty smoothly in that regard. The Medicaid expansion that we did here in Indiana, or the HIP 2.0, that has been more challenging. And what we see, yeah, that has been the part, at least for the last 5 or 6 months, that we get called in a lot in regards to that.
Of gaps within that?
Gaps, and just as they've implemented the program, things that we didn't know were going to happen. There's something called hospital presumptive eligibility, or we call it HPE, that was touted as this great and wonderful thing that when people come to the hospital, they will be screened immediately for HIP 2.0. And if they're eligible right then, they'll start coverage. So we were all very excited that this was coming down.
Pretty reasonable.
Yeah, couldn't wait. What we found was that they're getting coverage right away, and they're saying, yes, you're going to be signed up for HIP 2.0 as long as you complete all of your documents and turn them in within the next 30 days. So we were sending people out saying, you're covered, it's great, sending them to the pharmacy, but the pharmacy isn't able to access anything to see that they've got coverage. So they might have coverage at the hospital, but then when they try to go to the doctor or the pharmacist, no coverage for them.
It takes 30 days. Perhaps.
It's taking really longer than 30 days. We're seeing that sometimes it's taking 60 to 90 days for people to really get their full coverage. And people need services before that, like the home health that I've mentioned, or maybe they need to go to a nursing home for rehab, and we can't access those services because they don't have insurance yet. So
The stress level for patients and families probably.
absolutely.
Yeah.
Yeah.
Wow. Are there times when you get involved with patient care that medical staff has not referred you?
I mean, there's a lot of autonomy in who I see outside of those referrals that I mentioned.
Okay.
So it is up to me to sort of look at my list, and I might see and say there's an 85-year-old patient who's there, and maybe they have a chronic illness. One of the things I want to make sure is that they've had someone talk to them about advanced directives. Has someone ever talked to them about a living will? Do they have a healthcare representative that can make decisions for them if they ever are in a situation where they can't communicate? Because we end up seeing a lot of people who don't have those documents, and that can become very complicated at end of life. So that's someone that I would just see by myself and go in. I'm not sure, is there anybody else that's kind of coming to your mind that you're wondering if I see?
No. I was just curious, like if you had to follow a strict, these are the people who you see from the care manager.
Mm-hmm. No, I would say we have a lot of autonomy, and I'm lucky to have a director that I think they recognize that as social workers we have a unique skill set.
Mm-hmm.
There are other hospitals where I've talked to people that social workers and nurse case managers are kind of working side by side and sort of doing the same thing, but our director realizes that we've got some unique things and the nurses have some unique skills, and we're able to go out and see patients based on those sets.
Nice.
Yeah.
Well, Gena, we've covered a lot of questions here, and I'm wondering, is there anything that I may have missed that you would want to share regarding your role?
I would say medical social work is something that if you're interested in having a new day every single day when you walk into work, and you like that excitement, maybe crisis is something that's fulfilling to you. I know that sounds a little funny, but
I get it.
The people who enjoy it, they kind of get something back from being involved in a crisis and helping to see someone through that. If that's for you, then medical social work would be a great field to go into. So I just want people to know that.
Great. Well, I really think that is it, and I appreciate your time and your being willing to be interviewed, and I think this is really going to help out a lot of students understand hospital or medical social work.
Great.
So thank you.
I'm happy to do it.
Yeah.
Thank you so much.
Okay.